Hello, listeners. Welcome to Born Curious, coming to you from Harvard Radcliffe Institute. I'm Heather Min.
And I'm Ivelisse Estrada. On this podcast, we occasionally consider pressing issues through the work of practitioners working on the front lines.
One of those issues is breast cancer care. As it turns out, advances in treatment have not improved survival chances across the board, mostly because there are healthcare inequities that exclude certain people from access.
So today, we're talking to someone who for years has been providing cancer care to underserved populations. We're here with Naomi Ko, who's Section Chief of Breast Cancer Medical Oncology at New York University Langone Health and an associate professor at NYU Grossman School of Medicine. Welcome, Naomi.
Welcome.
Thank you so much for having me.
We're so excited to speak with you. So, to start us off, what do you do as a physician scientist?
First and foremost, I'm a doctor, and I care for a patient, any patient who walks in the door with a breast cancer diagnosis. I'm also a scientist in that I want to care for the woman or man who walks in the door, but I want to make a difference to even the patients that I'm not going to see. And that's how you do that, through research and science. And so it's in the study of medicine that we can have a bigger impact than just in the clinic. From little things like you see an interesting case and you write up the report and you publish it. You see a pain point in your clinic and then you decide, I'm going to study that. I'm going to collect more data and figure out, is it just me? Is it more people? And then you publish it. Or you do that kind of research all along the way.
So research doesn't mean you're looking at cancer cells on a petri dish under a microscope?
That's a really common misunderstanding at times of what is research. And research is being curious, actually. It's just being curious and wanting to learn and make a difference and improve that in the field of medicine. And so that's how I see it. I say, I just want to understand better. And if my desire to understand better is going to help other people understand better, that's research.
And what are you trying to understand better?
Yeah. So the research question that has shaped my entire career has been a passion I have around health equity. And making sure that you have an equal chance of surviving breast cancer no matter where you live, no matter what your background is, that everyone deserves an equal chance for a cure. And unfortunately, that's not true. And so women right now, if you're Black, you have a 40% higher mortality rate from breast cancer. And I've spent my entire career trying to understand why and how to ameliorate that mortality gap.
And this is in the U.S.?
Yes, in the United States.
So it's 40% higher risk across all ages?
Yes. So if you look at Black-white racial differences, you can see trend lines that start to separate in about the 1980s approximately, where the mortality rates all decline. We're doing better at curing breast cancer, but a lot better for some than for others. And if you look at racial lines, just the racial lines that's adjusted for other factors, Black women have a much higher rate of dying than white women do. And unfortunately, that gap is widening.
Wow.
It's not closing. We're not closing that gap.
So why is that?
Yeah, I mean, how much time do we have? My research has delved into multiple domains, so you can look at it from multiple different angles, and it is a multifactorial issue. And I will say that every solution is necessary and insufficient. So you need a lot of solutions to get at this problem. So there's societal factors. There are biologic differences in tumor biology, tumor subtypes. Whether you believe in the science, whether you trust your doctors would make a very big difference as to whether you engage in the treatment plans that are put forward to you or not. There is things like access to care. That's very difficult for different people. Whether you have insurance or not is a big deal. There are a lot of different reasons why women don't get the same outcomes.
Can you remind us, do you happen to know what percentage of the American population even has health insurance?
Good question. I don't have that percentage now. It's a moving target sometimes.
Yeah.
It also really depends on what state you live in.
Mm-hmm.
And it depends on whether or not the Affordable Care Act was effective in your state, the health exchange, whether people can get on it easily, and all of that, how easily insurance is facilitated by the state in your state or not at all.
Mm-hmm.
And I think what's really concerning a lot of us right now is that we know Medicaid is going to be cut and that the people who left uninsured will grow. And that's concerning to figure out how are we going to still care for people. Ibram X. Kendi had said this, and something I heard him say once about how race and poverty are like conjoined twins. I think I got that right. But there's just something very connected between poverty and race, and it goes back to the racism in this country. And I know we've talked about the terms of structural racism and how we have born a society out of an ugly history we've had for Black Americans. And when that is part of the story, those lines have remained problematic. And so if you are poor and you're Black, if you're poor and you're white, it is difficult to get optimal treatment in this country for medical care.
And this is something that you yourself have seen?
Yeah. I mean, I have dedicated the last 15 years to working in a safety net hospital.
What does that mean?
It means that I spent my fellowship training at Boston Medical Center, where it's the largest safety net hospital in New England. And basically, it's the place where you go if you don't have insurance or you can't pay. And it was formerly Boston City Hospital. And that is where I did my fellowship, and largely because I really felt that that was where the patients needed me, that was the hospital that I knew I felt like I could make the biggest difference with what I really personally cared about. And so I went there and did my fellowship training there, and I really had an incredible mentorship, and I stayed on as a attending doctor there and had a panel of patients and subspecialized in breast cancer. And so all the women in Boston who didn't have an easy place to go would often, almost exclusively, end up at Boston Medical Center. And it was a privilege to take care of them there.
And are your patients people of color?
Yeah. So at Boston Medical Center, we see a predominantly high rate of women of color in our breast cancer program. I think, to my recollection, we had 40% Black, 20% Hispanic, or Black Hispanic, white Hispanic, and then we had 40% white. That was our demographic breakdown in the breast cancer population there. So it was a real mix, but we really saw a lot of women. We had some mix of private insurance, but predominantly publicly insured patients.
Who gets breast cancer? Is anything? Can we do anything to prevent or avoid even getting it?
Yeah, great questions. There's a lot we know that predisposes women to risk of breast cancer, and being knowledgeable about those risks and taking them to your own personal behavioral needs is really important. So I'll just suffice it to say, we know that exposure to estrogen increases your risk of getting a hormone.
Women have estrogen.
Yes. Exposure to extra estrogen. So if you're taking hormone replacement, if you're taking estrogen extra, then you have a little higher risk of getting breast cancer. Good to know. You get your periods a lot earlier in life, and you never have a pregnancy, and you never breastfeed, your innate body has been exposed to a lot more estrogen over your personal lifetime.
Oh, interesting.
That increases your risk of breast cancer.
What about taking birth control pills?
Slight increased risk.
Really?
Yeah. Yeah. And so everything hormonally manipulated will have some effect on your risk of breast cancer. I have to say this very carefully. It doesn't mean that oral contraceptive pills are going to cause your cancer. It is just a slight risk, but you have to take a million different slight risks of who you are to really know what is going to determine whether or not you actually get cancer. And oftentimes we can't give you an explanation. So many of my patients are like, oh my gosh, Why me? I exercise. I eat well. I do a lot of things that to be healthy. How could I have gotten this? And so you have to do what you can and be informed about what we know, but also live your life and do the things we know to detect it early if you were to get it.
Is breast cancer the most common type of cancer that women, and yes, men get it as well, but women get?
Yes, in the United States, 1 in 8
1 in
women,
8.
What?
1 in 8 women will get breast cancer. And that's why it is just so incredibly important for us to be on air right now and talking about it. And we're really trying to get the message out to take care of yourself, you know.
And cancer manifests with age?
Yes, it is. The biggest predictor is the age. Age is your biggest risk factor. Having said that, new epidemiologic data is showing a tendency that age is skewing younger and younger in breast cancer. And it is actually very, very concerning to all of us in the breast cancer field is to think about how we're seeing women in their 30s pre-screening starting to get breast cancer. And so my other public service announcement is know your body. Know your body. Make sure you feel your breasts. You know, are they lumpy? Are they, just know yourself. And if you feel a change, seek help. It's get an ultrasound. Just make sure. I really want women to be empowered, to both know themselves, the self-awareness, but also the self-advocacy to go do something if they find something.
So we should be able to feel something if we do self-exams, but mammograms are important because you can also have it and not be aware of it.
Yeah, and I would even say you sometimes can't feel it. In fact, you can't. And so it's only if you do feel it and catch it early. Again, the name of the game is catch it early and seek help. There are a lot of psychological steps there. You have to know your body, be willing to feel your body and know it well, and then be able to go seek help if you do find something wrong.
Can you remind us what the current guidance is?
Yes. Yes. Annual mammograms starting at age 40 is the current guidance.
I mean, you talk about how many people this disease touches, and, it's not just family members, it's friends too.
Oh, yeah.
Yeah, and I mean, that's 1 in 8.
Yeah, it's a lot. And sometimes suffering from this disease can be very quiet. There are a lot of the stories that I have of women who were very scared to share their diagnosis. There are women who are abandoned by their partners, and that's really, really painful, a really, really painful part of this. I've had women who are working and were too scared to reveal their diagnosis because they felt that they would be, not given stuff to do at work and would be seen as weak. And then there's a lot of what I call cancer trauma in the communities that I cared for. So in Black and brown impoverished communities, the C word is very scary because they see a lot more death and dying from cancer in a pretty, at times, ugly and undignified way. And so sharing that you have a cancer diagnosis is a vulnerability people don't want others to perceive them as.
So can you share with us, for people who, don't work as a physician or are not at the front lines of doing breast cancer research, what's the landscape at this moment in terms of treatment options, rates of success upon receiving treatment?
Sure. So I like to tell everybody that breast cancer is not one disease. And so you really need to understand and have knowledge of what subtype of breast cancer you have. So right now, currently in breast cancer, there are 3 main subtypes. There's the hormone-positive breast cancer, then there's HER2-positive breast cancer, and there's triple-negative breast cancer. So they behave differently. They present differently, they grow differently, they metastasize to other parts of the body differently, and as such, we've developed different treatments for each of those subtypes. So all of it depends, like whether you survive your breast cancer diagnosis and what treatment options you have really depends on that subtype initially. The other major factor is whether or not how far it's spread. How much tumor burden do you have in your body? And if you're early stage, if we are able to catch any of the subtypes early, your chance of surviving is so much greater. And I've been saying this like on repeat. Make sure everybody gets their mammograms. It is worth it to catch things early.
And I'm guessing that in your practice, this was not, you didn't always have the ideal situation.
Absolutely not. And so when you don't have health insurance, when you can't speak English, when you work 2-wage jobs 6 days a week, it's very much harder. Much harder to go get that mammogram. In fact, impossible if you don't have any access to care. So a lot of the patient stories that I encountered in my tenure at Boston Medical Center were women who came delayed to care. For one reason or another, it just took a while to get there. And unfortunately, when that happens, cancer doesn't wait and it grows. And so we saw a lot more later stage breast cancers than some of our colleagues around town see because we're catching them later. And a lot of them we can still cure and some of them we can't. One of the things that I've been really contemplating a lot is this very segregated system of care that we do have in the United States. And where you get access to care has everything to do with your pocketbook. And it really does. It's just whether you're insured or not is a real bifurcation in the options that you have. Many different cities and areas where the training hospitals were the safety net or free hospitals, and those were for patients who didn't have any other options. And then often across the street or just down the street grows this very fancy, at times, academic. It's not a private hospital, but it's for people who have private insurance. So you're building 2 hospitals in geographic proximity to each other that service very different patient populations. Let's talk about Bellevue and NYU, where I am now. Same story. There's Boston Medical, and then there's Longwood Avenue, and all of the hospitals, like, a mile and a half, 2 miles away, and very different patient populations. And it's been set up that way, entrenched in policies, in funding, government, state funding, and all of that has created systems like this. It's a tiered system.
And can you talk about the difference in care that one has options to?
Yeah. So I think one of the biggest differences, at least in the oncology space, is access to clinical trials. Traditionally, as it stands now, a lot of clinical trials are run out of academic medical centers. A lot of those academic medical centers are places that people go to if you have insurance and are very difficult to gain access to if you don't have insurance. Therein lies the issue, right there. And so the patients that I saw at Boston Medical Center, we also had clinical trials, to be sure, but the clinical trial infrastructure was just not as robust. And it's expensive to open clinical trials, but the fallout and the downside of that will be that certain populations get access to certain clinical trials or not. And then what ends up happening is that those clinical trials is what's guiding our standards of care. So if you think about it this way, all of the medical science evidence data with clinical trials around treatment are guided and studied in a single population. So it is one of the reasons I think the gap in mortality that we started this conversation talking about continues to widen, is because we're not taking into account different populations that are different and that may not respond exactly the same way.
Does it also mean that promising treatments, get a special preview with better off populations?
Yeah, I think that is true. Honestly, it is, because if you are in some cases, some people with cancer, when they don't have any more standard options left, and they want this is like a treatment that may still be up and coming, but being tested still, there's a lot of opportunity to get on something like that. At NYU right now, we're working very hard at opening clinical trials at Bellevue.
And this year, you're the Mary Beth and Chris Gordon Fellow here at Radcliffe, and you have brought a project. Can you tell us about that?
Yes, I want to first say I am just so grateful and absolutely delighted to be a Radcliffe Fellow here. It is just such a dream come true. My project while I'm here is to write a book, and I'm really excited about it. It was a thing I've wanted to do for a long time, and when I found out about the Radcliffe Fellowship, it was just the perfect mechanism for me to actually do it. So that's why it just feels like such a dream come true. I've wanted to write a book on the patient's stories because, as I mentioned earlier, as a researcher, there's only so far that data and numbers and sometimes academic publications can go. But the patient's story can take you farther, and it can really give you a much more complete picture of what is going on and some of the phenomena and trends that I've seen in my 15 years treating patients at Boston Medical.
So have you conducted interviews with your patients? How are you telling these stories?
Yeah, I'm doing this really largely from memory. They're really stories from my clinic. Dear patients of mine that are remarkable women. I have had this practice where ever since I started seeing patients independently, meaning after my training, I would print out a physical piece of paper that had my clinical schedule on it with all the patient cases. And as part of my own routine, I would print out this paper and make annotations and notes on every patient. So I would review their record and I would take notes and say, oh, okay, I need to ask about this and I don't want to forget that. And then after clinic, I had my notes with me and I'd have these check boxes that said, need a scan or lab work or call their daughter or, all those little notes. And I have this annual binder and for each year. And I've done this every single clinic. And actually this weekend, my plan is to over the weekend go through those very meticulously, is just go through each of those sheets and sort into buckets. I've already written the first chapter.
It sounds pretty like it could be pretty emotional.
Yeah. I mean, yes, it's making me feel sad just thinking about all the women that I've had the privilege, the real privilege, to be in the service of, and sharing their journeys, sharing their stories collectively, pulling out the themes that kept coming through in my career that need to be shared is the gift of what I'm able to do hopefully this year here at Radcliffe.
Who is this book for?
It's for you and you and you. It's for everyone. It's for everyone because we all have experience with cancer in one way or another. Cancer is known to so many, and it's hurtful and it's sad and it touches so many lives around the world globally, but in America. And I want people to read this book and be able to walk those steps with me and with my patients in a shared journey of, I get it. I get that. I've been there. Wow. Because it's a very human story. And I want to be able to capture that for people. And specifically, really, I want to capture the stories of women who don't usually get their stories told. They're not at the front of what we see all the time. And one of the reasons for that is because it's about equity. It's about saying, for people who don't have the resources, the time to do what others can. I want to be able to uncover their joys and their dignity, and also potentially what we can do to make sure we keep an eye on equity going forward.
Yeah, because can we talk about kind of the image of breast cancer
Yes.
awareness
Yes.
right now in this moment?
Of course. And often it's white women are really seen a lot and exposed a lot. One of the things that I recently talked about at my Radcliffe talk was about Audre Lorde, our Black feminist poet, warrior. And she wrote an incredible book called The Cancer Journals about her personal journey with breast cancer. And she wrote it because she felt at the time there wasn't any space for Black women's stories. And and I'm thinking about my book, I want to help ameliorate that showing their different perspectives of what it means to get breast cancer. It's not just the same people. It's let's shift the lens a little bit and see what's often unseen. And one of the proposed potential titles for my book is Seeing the Unseen Among Us, because we're all in it together. We all share this plan together and we need each other. And some of our perspectives are not as often shared or seen. And I think hopefully that's what my book can bring to the public.
Can you share with us any stories about particular patients? Is that possible?
Oh, yeah. I think I got permission from one of my patients for my Radcliffe talk to tell her story. This is a woman who got a lottery green card, and she was like, wow, I have this chance to America. And she had 2 kids back in her home country and her husband, and she's like, I'm going to take it. I'm going to get there, and we're going to all immigrate to America. And she's Black, and she came to Boston, and she rented a room, and she started working 2 shift jobs to pay for the room and to get herself going. And then she started to notice a breast mass. And her type of breast cancer is the HER2 positive type, which is a very rapidly growing aggressive tumor, actually. And she didn't have insurance. She didn't know where to go. And she's like, maybe it'll go away. We always say, how many times you're like, oh, I have a cough. Oh, maybe it'll go away, right? But when it starts getting persistent and it doesn't go away, then the worry and anxiety starts to seep in. And she didn't have insurance, didn't know where to go, and ended up landing at the emergency room at Boston Medical, which is a common stop for a lot of people without insurance and a concern and having nowhere else to go. So luckily she got to Boston Medical. She went through the process of having to get urgent imaging, urgent biopsy, urgent visit for biopsy result, urgent follow-up visit with an oncologist. All of that, by the way, takes time away from her jobs, 2 jobs, to do all of that. And it was stressful, and she was alone. And I met her, and we just carried her through. And it took a lot. It was frightening. And eventually, she got on her chemotherapy and targeted their antibodies, which are very powerfully, a great treatment for her HER2 positive breast cancer. And she had an excellent result. But the process of going through that was incredibly challenging as she was alone, and she did not take time off work.
Wow.
To do it. And one of the main side effects of chemotherapy can be that, well, first you lose all your hair. Second, you can even lose your nails because the chemotherapy treats rapidly dividing cells. So your hair is always obviously growing and your nails are always growing. And so she lost her hair and her nails, and she started to get infections in her nail beds. And she made sandwiches as one of her shift jobs. And I said, honey, you gotta stop wearing those plastic gloves for, 6 hours at a time. That's awful. We can't keep up with these localized infections. And she said, I can't afford it. I cannot afford it. I just double glove. Get in there, make the sandwiches, air them out when I get home.
Wow.
And that's real. That's real for people.
How long did you see her? How long did this?
Well, her chemotherapy treatments were about 4 to 5 months after diagnosis. And then she went on to surgery. And after surgery, you have radiation. And after radiation, you have more therapy. I mean, right now in breast cancer, it's a long journey to get to cure. So for a lot of women, it's not a simple time change. It's a period or phase of your life that can often be a year to 2 now. It's only growing. We keep giving people more medications that we know prove a benefit in the long run. But in the acute setting, that's a lot to ask when you don't have reserve. You don't have financial reserve. You don't have anything. You don't have a safety net of your own. And so there are many, many stories that I'll hopefully be able to illustrate in my book of what that looks like. Financial toxicity is another term that's used in the academic medical literature a lot that depicts what that means when you get a cancer diagnosis and you go almost bankrupt and indeed bankrupt. And you had insurance because it's about the co-pays and not being able to go to work. And everyone's unique situation is different. And so how you make it through a journey really is a unique circumstance.
But your patient, she made it through.
She made it through. She made it through, and she's so grateful. I feel like that's the other part of what I love about my job is being there at that moment for my patients too. I want you to be happy. And how are you going to thrive in your new life now?
Thank you.
Thank you so much for having me.
That concludes today's program.
Born Curious is brought to you by Harvard Radcliffe Institute. Our producer is Alan Grazioso. Anna Song and Cabin 3 Media provided editing and production support. Many thanks to Jane Huber for editorial support. And we are your co-hosts. I'm Ivelisse Estrada.
And I'm Heather Min.
Our website, where you can listen to all our episodes, is radcliffe.harvard.edu/borncurious.
If you have feedback, you can email us at info@radcliffe.harvard.edu.
You can follow Harvard Radcliffe Institute on Blue Sky, Facebook, Instagram, LinkedIn, and Threads. And as always, you can find Born Curious wherever you listen to podcasts. Thanks for learning with us.
And join us next time.